participation in this venue.
You're welcome.
Good evening, Professor Dodi Subadi. How are you
Good
doing?
evening, Dr. Peter. Fine.
Thank you
Yeah,
very
good
much for
evening.
participation.
All of you.
Good evening, Professor Dodi. Thanks for joining this webinar. So we will get in 7 minutes.
Okay.
Good evening, Professor Paul Tahalili. Who is speaking here? Good afternoon, Professor Santos from Portugal. Good evening, Professor Hendy Hendarto. Are you on the line? In 7 minutes.
Okay.
Good evening, Professor Paul Tahalili. Good evening, Dr. Frans Arifin. Good evening, Dr. Diah Asmarawatie.
Yeah, good evening, Dr. Peter.
Good afternoon,
Thank you for your
Professor
contribution,
Santos
Dr. Diah.
from Portugal. Mr. Bimo, I think something is going wrong because my voice is have an echo. Professor Hendy Hendarto, are you on the line? Hello, Mr. Bimo. Please check it out about the voice. Because that's not my current voice. I think my video is going wrong. I should. Good afternoon, Professor Santos. Are you on the line already? Good evening, Dr. Frans.
Good evening, Dr. Peter. Just a moment, trying to find my video system.
Okay. Good evening, Professor Maliawan. Good evening, Professor Hendi Hendarto.
Good evening, Dr. Diah. Hello. It's very long time we cannot meet, right? Dr. Diah?
Yeah.
Hello.
Yeah, Doc. Good evening. I'm fine.
Yeah.
How are you, Doc?
Oh, fine, thank you. Did in Sutomo you it's already active like usual or still working from home, Dr. Diah?
I think Radiologist must go to the hospital and to active for ultrasonography.
Okay. Okay.
Thank you.
You're welcome.
Good evening, Professor Maliawan. Good afternoon, Professor Jorge Manuel Nunes dos Santos. Are you on the line? We will get started very soon. Good morning, good afternoon, and good evening, dear participants, especially our speakers for this webinar. Today, we will run the 19th chapter of the Surgical Forum of the International College of Surgeons Indonesian section. So for today, our theme will be the surgical knowledge and skill. And as your moderator for this evening, I would like, on behalf of the ICS Indonesia section, to welcome all of you and to express my gratitude for all your participation in this webinar of today. I think we have come to the opening session, and for the first opportunity, I would like to invite the President-elect of the ICS Indonesia section, Professor Sri Maliawan. Professor Sri Maliawan, the floor is yours. Professor Sri Maliawan. Maybe he will join us later on. For the next opportunity, I would like to invite Professor Georgios Tsoulfas, the World President of the International College of Surgeons, to address the message of the World President. Professor Georgios Tsoulfas, the floor is yours. Okay, maybe later on. And I will skip, and for the next opportunity, I would like to invite Professor Hendy Hendarto, the Vice President of the International College of Surgeons Indonesia section, to address the scientific notes. Professor Hendy Hendarto, the floor is yours. Maybe later on. And for the next, I would like to invite Professor Jorge Manuel Nunes dos Santos from Portugal to address your introduction, brief introduction, as our guest speaker of this webinar. Professor Santos, the floor is yours. Professor Santos, are you on the line already?
Asmarawatie.
Okay, I will skip, and then I would like to invite Dr. Frans Arifin from the Indonesia section, the Secretary of the Indonesia section, to address the section issues. Dr. Frans Arifin, the floor is yours.
Thank you, Dr. Peter. So there is not much. I think I would like to remind everyone that the 42nd ICS World Biennial Congress will be commenced soon at the 17th to 19th of November this year. It will be online, and I would like to invite everybody, the fellows of Indonesian College of Surgeons, and anybody who are interested in the activity to join the Congress. The Congress actually will be held partly in online and partly offline, on site at the Movenpick, Thailand. So for the fellows, the information is posted at the WhatsApp group for everybody. If anyone is interested to present or to provide any abstracts, you are welcome for that. I think. And the second one is that in this year the International College of Surgeons Global is now in the process of renewing some of the committee members. So there will be some new and some old members. Also, the president of the ICS Global, the president-elect, will be the president for the next 3 years. I think that's all for the section brief. Back to you, Dr. Peter. Thank you very much.
Dr. Frans, could you update about the information of the World Congress in Bangkok, the upcoming World Congress in Bangkok, Thailand? How about the situation of the pandemic in Thailand or in Bangkok? Is that safe to join on site?
Actually, from the committee, there is still they are still waiting for the last condition or situation. I think there will be some announcement in the next few weeks. I think 2 or 3 weeks before the date, Dr. Peter. They promised, I contacted the committee, and they said they promised to update the latest condition maybe about 2 or 3 weeks before the November 17th. Currently, they are still planning for the mixed Congress, so it's online and on-site. So, but because of the changing of the situations, they will provide the updates near the date of the Congress. Perhaps in the next month's session of our meeting, I think we can. I can give more detailed information.
Thank you very much, Dr. Frans, for your update information.
Thank you, Dr.
And,
Peter.
Yeah, you're welcome. And then I would like to invite again Professor Sri Maliawan, the President-elect of the Indonesian section, to address the opening speech. Professor Maliawan, the floor is yours. Or maybe later on, Professor Hendy Hendarto, would you please address your scientific notes? The floor is yours.
What happened to all these people?
Okay, then I will start with the scientific session, and the first opportunity will be for Dr. Diah Asmarawatie, radiologist. She will speak on imaging during surgery. Dr. Diah Asmarawatie, the floor is yours.
Thank you, Dr. Peter. Thank you, Dr. Peter. I would like to say thank you for the time had given to me to present the topic imaging during surgery. The topic imaging during surgery. Radiology as a diagnostic support must properly maximal and detail information to the clinician in getting the correct diagnosis. The information getting from plain photo, ultrasonography, CT scan, MRI, or PET scan are written by the radiologist and expertise. If the diagnostic likened to the colors, theoretically easy to differ the black color and the white color. But practically there are many spectrum between black and white color. For instance, the deep gray, the light gray, the very light gray, and so on, which make diagnostic difficult. For imaging during surgery, the topic discussed into 4 parts, that is from plain photo, ultrasonography, CT scan, and MRI. Plain photo, especially thorax photo, is necessary done before surgery for the surgeon safety in COVID pandemic. Thorax photo is a must before surgery. Moreover, in the pandemic COVID, it's very important for the surgeon's safety. The expertise can be normal, so the surgeon can do the surgery, probable COVID, indeterminate COVID, or non-COVID. People had been recovered from COVID. Some of them recovered, but the others had sequelae in their thorax. There will be a problem for the surgeon and anesthetist for the next surgery. The patient from the pulmonologist, it had been recovered from corona, but actually from the X photo, there's still a sequel, and there is a problem because if there's a next surgery for the patient. There is the picture of the corona and sequel. We see on the right side, this is a crazy paving appearance. We can see this, then this is usually see in the patient with COVID. And if the patient recovered, there's still a parenchymal band like this. We can see this, and there's still for several months after the patient recovered from the COVID. This is a subpleural GGO, ground glass appearance. Usually this is typical in the patient COVID. But if the patient recovered, there's still a parenchymal band here. This is the parenchymal, and this will be a problem for the next, for the surgeon and the anesthetist, like this one. You can see this in this photo. This is an example case. I will explain this from the plain photo ultrasonography CT scan. In MRI, a female 36-year-old complained discomfort at the side of the abdomen, formerly not palpable. But a female 60-year-old complained discomfort at the left side of the abdomen, formerly not palpable, but after 3 months, the mass slowly grew and bigger. The gynecologist done the ultrasound and think that it's an adnexal mass. The surgeon think that it's a lien aberrant. Blood test within normal limits. No problem with the menstruation, no pain, only feel discomfort at the left side of the abdomen. Ultrasonography done for the patient. Ultrasonography is safe because no X-ray, but very operator dependency. This is the right lobe of the liver, and this is the left side of the liver. It's a normal condition, and this is the gallbladder, and this is the pancreas. All is normal limits. And then there's the cavum uteri. This is the IUD, vesica urinaria, spleen, the right kidney and left kidney within normal limits. And this is a mass seen in the ultrasonography. The mass, it is still doubtful. So to the MSCT scan, which can be reconstructed for 3-dimension axial sagittal coronal district. On the axial slice, we see this one. The solid mass was seen regular age, sharp border, located on the left side of the abdomen. Parenchymal, minimal, and homogene. This is there is a rather dark and there is a light in this parenchyma, but still a good border on the environment of the mass. The margin of the mass very look clear, differ from the other organ. At the coronary side, we see this one, the mass is the solid seen inhomogeneous parenchyma, regular edge, sharp border, located at the left side of the abdomen. The size of solid mass is 5 times 8 centimeter. The solid mass located outside of the colon. Here's the colon and intestine. The border very clear here. In the sagittal size, we see the solid mass outside of the range. This is still outside, and the spleen, this is normal limits. There are no lien aberrant solid mass located in the skin parenchyma. No invasion to the surrounding. I think it's important to the surgeon, the information that the mass, no invasion to the surrounding. It's still good. It's here. And this one, at the coronal plane, we see the right and left renal in the normal position. No correlation between the ren and the mass. The liver in normal limits, no correlations in between the mass and the liver. The lien also in normal, no correlations in between the mass and the lien. Solid mass located clearly in the scan parenchyma. Here, no invasion in the abdominal cavity. This is the post-operation. The PA, pathology anatomy, the conclusion is a mesenchymal tumor, spindle cell. The differential diagnosis, deep aggressive fibromatosis, leiomyosarcoma, dermatosarcoma. From immunohistochemia, the conclusion is desmoid tumor. The other cases, here I seem to hemangioblastoma. This the little boy, this is the hemangioblastoma. In this picture, this is important to the surgeon because this is the artery feeding. The artery will give nutrition to the tumor. The patient twice operation because the first operation, the surgeon think that it's not a hemangioblastoma, and when the operation, there's much bloody and it's closed, and then after this, do this second MSCT, and now that this is a hemangioblastoma and this is the artery feeding. And after this, the surgeon do the second operation and it's success. Because the surgeon know that this must be careful with the artery feeding. This is the other example of the mass in the left scapula, defect of scapula. Actually, it's only a soft tissue mass here, like this, the soft tissue mass. But after the CT scan do the reconstruction of the bone, we know that the bone had defect here by the mass. So it's important to give the detailed information to the surgeon. These other cases of meningioma. This is, we can see this is the still in good, it's between meningioma and other brain tissue. It's important to the surgeon, and there's no defect for the scalp. Still good distal, and this the patient had operated and success. MRI, especially for the musculoskeletal, very helpful to the surgeon like this. With the MRI, we can see this, the spondylosis lobalis and the scoliosis to the left side, the apex and the corpus of vertebral lumbar 3, the angle about 11 degrees. And we can count this from the workstation in the MRI. This is the same patient, and this is, we can see this is the stenosis canalis spinalis in the 3rd degree between the vertebral lumbar 5 and sacral 1. This is, I sent the several example of cases which meaningful that the radiologist must give the complete information, maximal information and detail to the surgeon for the successful operation. The conclusion, plain photo, especially thorax photo, is necessary done before surgery for the surgeon's safety in this COVID pandemic. Ultrasonography is safe because no X-ray, but very operator dependent. MSCT scan can be reconstructed for 3-dimension axial, sagittal, coronal. That is very helpful to the surgeon, and MRI, especially for the musculoskeletal, very helpful to the surgeon. Thank you.
Thank you very much, Dr. Diah Asmarawatie, for your informative presentation. And now we come to the second speaker, Professor Jorge Manuel Nunes dos Santos from Portugal, to deliver his presentation on the general management of the Peritonitis Generalisata. Professor Santos, the floor is yours. Maybe later on he will join us. I will skip, and for the next opportunity, I would like to invite Dr. Menik Sayekti, candidates of oral surgeon, to address her presentation on the surgical management of Ameloblastoma. Dr. Sayekti, the floor is yours. Please unmute your microphone.
Thank you, Dr. Peter. Can you hear my voice?
Yeah, clearly. Thank you.
Good evening, Professor, Doctor, and all the participants of International College of Surgeons Indonesian section. It has been my honor and pleasure to meet you all here. I am Menik Sayekti, Chief of Residence Oral and Maxillofacial Surgery from Universitas Airlangga, Surabaya. In this good opportunity, I would like to present about surgical management. I'm so sorry.
You are missing your slide. Okay, perfect.
Wait.
I cannot see your slide.
Wait a minute.
Yeah, okay. Oops.
Wait.
Please go to the share screen, the green one in the bottom of your monitor, the green one.
I'm so sorry. My computer is in trouble. Maybe you can wait 1 minute again.
Okay, we will wait for a moment. Yeah, your slide appears clearly.
Sudah. Can you see my screen?
Yes,
Can-
clearly.
Oh, yeah. I'm so sorry. Good evening, Professor, Doctor, and all the participants of International College of Surgeons Indonesian section. It has been my honor and pleasure to meet you all here. My name is Menik Sayekti, Chief of Resident Oral and Maxillofacial Surgery from Universitas Erlangga Surabaya. In this good opportunity, I would like to present about surgical management of ameloblastoma. Ameloblastoma is a benign odontogenic tumor of the jaw originates from residual epithelium of tooth germ. It represents approximately 1% of oral tumor. About 80% of ameloblastoma occur in the mandible, mainly the third molar region, and the remaining 20% in the upper jaw. The most cases location ameloblastoma is in the posterior mandible, while the lowest cases is in anterior maxilla. For Atheopathogenesis, there are several theories that have been put forward, including trauma, inflammation, nutritional deficiencies, non-specific irritation, and dental caries, including genetic factors, morphogenesis, cytodifferentiation, and tooth patterning. And I'm sure we all know a lot about the clinical appearance of the ameloblastoma, such as symptomatic swelling, growing slowly, expansion of the jawbone, and can penetrate the cortical bone, causing infiltration into soft tissue. There are two types of treatment for ameloblastoma. The first is curettage, and the second is resection. We prefer doing resection than bridging or curettage. Since ameloblastoma itself has feature of high recurrency rate. Well, with resection, we can reduce risk of recurrency. However, the method leads to a critical size defect requiring another surgical reconstruction procedure. WHO 2017 classification divided ameloblastoma into 4 categories: conventional, extraosseous or peripheral, unicystic, and metastatic ameloblastoma. Metastatic ameloblastoma was moved to the benign ameloblastoma subtype from the malignant odontogenic tumor. The most important reason for this is both the primary and metastatic ameloblastoma are histopathologically identical to benign ameloblastoma. Disease related to bone tissue are still the main morbidity in people over 50 years old. Although bone has the ability to regenerate, this does not occur by itself in extensive bone defects that do not spontaneously heal without intervention and are generally considered those that result in a bone loss of greater than 50% of the circumference of the bone and at least 1 to 2 centimeters in length. And post-operative defect, one of the classification system in literature to describe the mandibular surgical defect is HCL classification. H for hemimandibular, C for central, and L for lateral defect. Pre-surgical preparation is an important stage for the patient who will undergo a surgical intervention and for the medical staff. The way in which it performed can influence the evaluation of the healing process by avoiding a major complication. Some example of complication are poor accuracy of reconstruction, a long ischemic time and duration of the entire procedure, and risky maneuver involving the vascular pedicle and perforator. There are 3 stages through people surgery that the first is 3D reprinting and pre-bending, then ramus fixator and surgical stent. 3D reconstruction aim to make it easier to manipulate plates so that walking time in the operating room becomes shorter. Here is the picture 3D reconstruction and pre-bending plate. The left one is 3D CT scan of the patient, and the center one is 3D reconstruction model, and the right one is the pre-bending plate accomplished prior to surgery. The Ramos Pisato issued when performing segmental surgery, which serve as a guide for occlusion. Surgeon may lose in orientation during forming the reconstruction plate into a horseshoe shape form of the mandible, as well as during plate placement. The plate can only be well adapted when the position of two distal end of the resected mandible bone are in a stable position. Then surgical stand is used as a guide to facilitate the placement of the plate during surgery. Then surgical approach, a variety of surgical approaches are available for mandibular resection. This done approach, comparing to other approaches, does not require identification and visualization of the marginal branches of the facial nerve. Operation technique, the first step is skin incision, 2 to 3 from inferior part of the mandible, then dissection superficial cervical fascia, after that dissecting platysma. The last one is dissecting the cervical fascia. Risdon approach, incision placed 3 centimeters or more below the inferior border of the mandible because of the close vicinity of the marginal branches of the facial nerve to prevent the damaging of facial and nerve facial bundle. Surgical reconstruction without reconstruction, mastication, speech, and facial aesthetic are often severely compromised. If we want to talk about various reconstruction technique, we have to know the advantages and the disadvantages of every single technique in order to establish a most proper technique for every cases. One of reconstruction plate we used was created by our Professor Kuhn, our teacher, which was called as Kuhn's 120 degrees angle reconstruction plate. It consists of the with condyle and without condyle. To overcome the problem of fracture plate due to over manipulation during the plate adaptation and forming in the angular region. The plate used for bridging plate can be used for primary reconstruction, cannot be used to support a denture. It was made from stainless steel material instead of titanium because titanium is not cost effective. Basically, autogenous graft for reconstruction was divided into vascular graft and non-vascularized graft. Both of them have their own indication and contraindication. While talking about bone substitutes, there are some materials that can be divided into 4 materials based on their source and properties. They are autogenous, allogenic, alloplastic, and xenogenic. If we are talking about how to choose the technique between vascularized and non-vascularized, there are some factors we need to take into consideration, which are quality of the soft tissue environment, adequacy of the soft tissue, size and contour of the defect, and the experience of the surgeon. There are 2 types of graft based on the vascularization. There are vascularized bone graft and non-vascularized bone graft. Vascularized to treat big defect bigger than 6 centimeters, while non-vascularized graft treat small to medium defect. Both of them, based on the research, BG et al., found almost similar outcome and similar morbidity such as inflammation, infection, and chronic pain for donor side. And non-vascularized bone graft in our maxillofacial department, Faculty of Dentistry, Universitas Erlangga, we usually use graft either bone from iliac crest and from ribs. This picture describes about graft manipulation taken from iliac crest. The first picture shows the harvested graft, and the second picture shows the decortication process using low speed bore, and the last picture shows splitting and flipping the graft. Well, this picture describes about graft manipulation taken from costochondria. The first picture shows the harvested graft. The second picture shows the decortication process using low speed bore, and the last picture shows adaptation and plating. Decortication of bone provides a passage away from blood vessel and progenitor cells to have rapid access to a quiet bone regeneration treated site. Osteoblasts are derived from the periosteum, endosteum, and undifferentiated pluripotential mesenchymal cell in the bone marrow. Decorticate rib graft into the defect region and secure with 3.2 stainless steel wire with the chondral section inserted into the temporal fossa for chondral replacement. This picture displays adaptation reconstruction of the plate and the graft on the mandible. Case used as the basic knowledge of the decortication technique. Approximately 9 months, at which time the regenerative growth of the bone appeared to stabilize. At the time, histological examination revealed mature lamellar bone. This is a 3D CT scan 18 months after ribs transplantation. This is a 3D CT scan reveals 2 dental implants were replaced for prosthetic rehabilitation. And intraoral photo shows the final implant procedure insert crown. Mandibular resection in pediatric patient, the treatment plan for children's ameloblastoma is confused because physicians are worried of disabled at a very young age, but one thing should be remembered in the growth process. So spontaneous bone regeneration can be expected. First case report is about 15 years old male with ameloblastoma on left mandible. Here is the extraoral photos at the first visit. The OPG evaluation displays some huge unicystic radiolocystulation on the left mandible, confirmed by pathology anatomy examination later as ameloblastoma. It can also be seen there was an embedded third molar below the lesion. This picture shows a hemimandibulectomy procedure using gigli saw, and in the right side reveals a surgical specimen. The result 9 months of the surgery radiography shows that was a plate attached on the mandible from region left posterior mandible, extending to area 31. The picture also displays the successful growth of the hard tissue around the plate. Here is the documentation OPG 7 days and 9 month follow-up after surgery. It can be seen that the newborn increased in height and thickness until approximately 9 months, at which time the regenerative growth of bone appeared to stabilize. At the time, histological examination revealed mature lamellar bone. Still on the left mandible, like previous cases, this is the extraoral picture of second patient of the ameloblastoma, 34 years old male. The OPG evaluation displays some white unicystic radiolocystulation on the left mandible from the apex of the left lower second molar extending to left canine of mandibular. This picture shows segmental resection procedure using gigli saw, and the right side reveals a surgical specimen. Here is the clinical documentation of 7 days after surgery and the OPG 7 days as well, follow-up after surgery. It can be seen that the bone has not been formed yet, so on the OPG only looks radiolucent. There are two of OPGs. The left OPG was taken and 7 days after surgery, while another OPG taken 1 year later. 1 year after surgery shows the formation of bone graft. Here is the documentation of 3 years after surgery and the OPG 3 years follow-up after surgery and after removing the plate. It can be seen that there was a growth of bone and the result was satisfying. The last cases is about 13 years old boy with ameloblastoma at anterior region of mandible. When patient come to Erlangga Hospital for the first time. The OPG evaluation displays some unicystic radiologist on the center mandible and 3D reconstruction. In this picture shows the ramus fixator is used when performing segmental surgery, which serve as a guide for occlusion. This picture shows segmental resection procedure using a Gigli saw, and in the right side reveals a surgical specimen. Here is the documentation of 4 years after surgery and the OPG 2.5 years follow-up after surgery and after removing the plate. It can be seen that there was a growth of bone and the result was satisfying. And the conclusion, first, mandibular reconstruction is very necessary after mandibular resection to support mechanical movement, aesthetic, and masticatory function. The mandibular reconstruction can be achieved using a reconstruction plate and bone graft. Non-vascularized bone graft, rib or iliac may be an option for mandibular reconstruction. Thank you for your attention.
Thank you very much. Yeah, thank you very much, Dr. Menik Sayekti, for your informative presentation. And for the next opportunity, I would like to invite Professor Jorge Manuel Nunes dos Santos from Portugal to speak on the general management of the general peritonitis. Professor Santos, the floor is yours.
Good afternoon, Professor George Santos. Unfortunately, cannot be present and asked to replace me in the last minute, so I'm sorry I got a little bit late. Professor Peter, thank you so much for the kind invitation you endorsed to our institution and to Professor George Santos, and it's a real pleasure to be here talking to you about this peritonitis. So, just start. So, okay. So Professor George and I, we are from the Portugal University. And this is our institution. We have no conflict of interests. And well, just to make a small remember a little bit from the anatomy of the peritoneum. We must remember that it is the largest serous membrane in the body with more than 22,000 centimeters square of surface area, and it has a visceral and a parietal portion. It has also exudation absorption properties, and in case of infection, he tends to stick together and to prevent the spread of the infection. Many times we call it the policeman of the abdomen. So when we talk about peritonitis, we are talking about inflammation of the peritoneum, which can be localized or generalized. And peritonism refers to the signs we find when we perform the abdominal examination. So when we talk about the generalized peritonitis, of course, we're talking about a surgical emergency, but we cannot forget patients must be, before surgery, of course, resuscitated and prepared for surgery. So the main causes are infective, and for bacterial proliferation is most common cause, and there are non-infection causes like leakage from some sterile body fluids like bile or urine, but even sterile, they may become infected in the first day or two. So we also like to classify in terms of types: primary, secondary, tertiary, and dialysis-associated. Primary peritonitis, spontaneous, many times in monomicrobial, and it's due to the translocation of our hematogenous CD. So secondary is that we are most commonly used to see, it's polymicrobial, and it's a breach in the mucosal barrier. Tertiary is the persistence of the peritonitis, and dialysis-associated, as the name says, is associated to peritoneal dialysis, and normally is from skin flora microorganisms. About the management, of course, you must always remember that diagnosis must be made as early as possible. Timely hemodynamics and resuscitation and even support of vital organ functions must be instituted as soon as possible. And to solve the problem, of course, you must take the appropriate measures to control the source control, and of course you must be backup. We have a backup with antimicrobial therapy. About the clinical features of peritonitis, always the pain is constant and severe. Normally is worsened with movements, and patients try to lie and stay still, not to feel pain. Many times we can also have an ileus with distension, vomit, and tympanic abdomen, and also in case of severe dysfunction, systemic shock like tachycardia, tachypnea, hypotension, lower urinary output. When we try to investigate these patients, you must make a history and of course the physical examinations. They will give us almost all the signs we need to address the problem. If it is localized, many times simple blood tests, X-rays, and some more image studies will be needed. Normally, we will perform image studies like CT or at least sonography. In generalized peritonitis, we cannot never to forget to perform a blood test and check for pancreatitis that can mimic secondary peritonitis. Severity is very important when we are talking about peritonitis, because as you can see, when we talk severity, we talk about organ failure, and it correlates very well with mortality. So as the organ failure prevails, more organs are in dysfunction, mortality gets higher and higher. So always check for hypotension, signs of cardiovascular dysfunction like hypotension and elevation of lactates, even urinary output, diuresis, and serum creatinine for renal function. Also PFO2 to see respiratory, then hematologic or liver functions. Severity is also related to the source. We know the common causes for peritonitis, as you can see in this work published in 2018. There is quite a proportion of patients with, when we talk about localized peritonitis, we are talking mainly about the appendix, the stomach, or the colon. But generalized, you can see it's more even throughout all the different range of origins. But when we have a patient with peritonitis, check for signs of organ failure and that you have to think about management. And that management must be as early as possible, quite effective, quite fast. So problem is not in severe peritonitis is not for residents, it's to treat the patient as fast, as effective, and as early as possible. And never forget about the support we must have from the intensive care team, so we can optimize the cardiovascular, respiratory, urinary systems. About supportive measures, we can administer immediately fluids to try to get some better tensions, hemodynamic stability. It might even be needed to have some vasopressors. In respiratory dysfunction, O2, supplemented O2, or even ventilation might be needed. Neurologic dysfunction might be just monitoring, but if the airway is compromised, never intubation might be needed. When talking about kidney dysfunction, start on fluids, try diuretics. You even might need some kidney replacement therapy. And when you talk about gastrointestinal dysfunction, many times you need to use endogastric tubes, or even don't forget after this problem, don't forget about nutrition of the patient, and maybe you will be needing parenteral nutrition. But when we treat fast, we talk about source control. And what is source control? Well, Marshall described that all measures undertaken to eradicate a focus of infection, to prevent an ongoing microbial contamination, to restore functional anatomy. And they include drainage of abscesses or reflected fluid collections, debridement of necrotic infectious tissue, definitive measures to control the source of ongoing microbial contamination to restore anatomy and function. So, and why source control? Well, all the studies done until now, you know, if we fail to achieve adequate source control, we fail to achieve treatment, and probably death will be the result to our patient. And the guidelines always endorse the need for early source control of intra-abdominal infections. This is a very interesting paper published in Clinical Medicine in 2012. It's about when we achieve, and the authors prove it, that when we achieve the source control, mortality is clearly reduced in the first intervention. So although overall mortality is quite high in intra-abdominal infections patients, 30%, when the source control was achieved, it reduced to around 10%. So it really is important. And for surgeons, there are two, when we talk failure of source control, there are mainly two ways we can, where surgeon has the most important role. So it's not to delay the initial intervention, so to make the diagnosis for the patient, and to in an early phase, and to make the decision to surgery if needed, or as fast as possible, and then to make the procedure more adequate to control the focus. So does always mean surgery source control? No. This is a study published in 2007 in Journal of Surgery, and it was in acute appendicitis complicated with intra-abdominal abscess, and they found that when conservative treatment was adopted, patients did fare well and better than when immediate surgery was done. So probably source control does not always mean surgery. And percutaneous drainage, when we have a localized intra-abdominal fluid collection, is a very good alternative with an overall success rate that can go to 90%, low complication rate, and we can, even if there is an unsuccessful, it can be tried as a second procedure, and operative management is needed in only a very few number of patients. So this is from the French guidelines, where they say that in hemodynamically stable patients and with intra-abdominal collection, it's image guided percutaneous drainage. It's a good alternative. So what can we do if is a laparotomy is demand for that patient? Well, we must do our surgical gesture according to the cause of the problem. We have the stomach, we can resect, we can just suture duodenum, just like the same, you can incisional or resection or even suture. Small bowel, is there resected? Is there, can we perform a primary anastomosis? Well, it depends on the local conditions, or we need to do an enterostomy. So large bowel exactly the same. Appendix, probably appendectomy will be enough. If the origin is gallbladder, of course, you need to perform a cholecystectomy, and the biliary tree, probably the best source would be to drain the biliary tree. And what about minimal invasive options, laparoscopy? Well, yes, they are an option. Well, we have tried. In patients with severe conditions, probably not the best options. Once again, in patients with shock and admission, high ASA score and more than 25 hours of symptoms, laparoscopy is not, probably will fail to control the source, so it's not recommended. And also laparoscopy in G4 patients with diverticulitis, also not recommended. So in the last few years, we are in trauma, we are trying a damage control option. This is only do the things fast and not solve all the problems in first contact. And is a damage control option available in case of peritonitis? Probably yes. This is some good studies about it. And what can we do in a damage control? Well, resection without reanastomosis, temporary drainage, abdominal packing, or temporal abdominal closure. So in what situations, what potential indications? Patients who are clearly in hemodynamic instability, critical conditions, with the excessive peritoneal edema that do not allow to have a safe abdominal closure, where the source control was not definite, and there is some necrotic tissues, when we don't know if the bowel remaining is viable, or we still have, for example, a large uncontrolled bleeding. So what about stage laparotomy? We perform a big surgery in patients with peritonitis. Should you go check it, or just in a non-demand situation? Well, Van Hoel in 2007 just showed us that there is no difference in mortality in a non-demand laparotomy, although there is a slight trend towards lower mortality in those patients. Morbidity was similar, but there was a reduction in relaparotomy, self-care utilization, and medical costs. So probably a better alternative than the decision to always perform a relaparotomy. Well, I talked earlier about antibiotic therapy. So where do we start, how we do it, and when to end antibiotic therapy. So if you go to the Surveillance Sepsis campaign, they always say that IV antibiotics should be initiated as soon as possible in case of sepsis and septic shock. Those patients with acute peritonitis do have sepsis more. Empiric-warranted antibiotics should be a broad spectrum and cover all likely pathogens. And therapy should be narrowed once the pathogen is identified and we have sensitivities. So when you talk about abdominal, we know that mainly we'll have gram-negatives and anaerobic bacteria. So we should start probably a single agent like broadband piperacillin tazobactam, imipenem, meropenem. But these decisions should always be adopted according to local profile of susceptibility of our microbiota. Obtain cultures, although not needed in secondary peritonitis, most of the organisms are from the community acquired, but it will help us to take decisions later probably, and adjust to a narrow spectrum once you have the identification of the organism, and do it for adequate time. So when should we, what is the timing from the antibiotic therapy? When should we stop it? There is a trend towards, in all literature, towards reducing or starting a short course antibiotic therapy. And the studies, you see, this is published in 2015 in New England Journal of Medicine by Sawyer. And there was no difference between 4 days and 8 days or later. Also, the same thing in 2017, published in Surgical Infections by Cole. So they recommended a shorter duration of antibiotic therapy. And as Professor Jean Hart said from the University of Carolina, all the evidence goes to that direction, that a shorter course antibiotic therapy is at least not worse, and there's some good benefits like reducing costs, avoiding selection of strains, more resistant strains, and pseudomembranous colitis. So always try to reduce to the optimal time of the patient. Mackenzie published in 2019 this optimal duration therapy. It goes from 24 hours or less to 7 days, but always check for your patient if things are going okay. And just to end, remember that to have a good result in case of peritonitis, we must see the patient as a whole and start as soon as possible. All our interventions, not delay, and surgery is just a part of all the treatment the patient will need. Thank you for your attention, and we will be more than happy if you have the opportunity to come to Port and visit us one of these days. Thank you once again.
Thank you very much, Dr. Vitor Simoes, for your informative presentation. Now we come to the discussion session. Before I open the discussion to the floor, the first part of the discussion will be the inter-speakers discussion. So I would like to provide the opportunities for each speaker to ask questions to the other speaker. And for the first opportunity, I would like to give or to invite to Dr. Diah Asmarawatie to ask question to the other speaker. Dr. Diah Asmarawatie, the time is yours.
Thank you, Dr. Peter. My question to Dr. Menik. Dear Dr. Menik, based on your experience, how many % of field reconstructed operation? Thank you.
Dr. Menik, would you please react to this question? Dr. Menik, please unmute your microphone. Do you have another question, Dr. Asmarawatie, to Dr. Vitor Simoes? Because maybe Dr. Menik is not on the line at the moment.
No. Hello?
Yes.
Can you hear my voice,
Yeah,
Dr.
okay.
Diah?
Yeah.
please.
Yes.
Yeah.
Until now, we still are collecting the data from our patient and still follow up the patient 1 year, 2 year, and 3rd years after surgery.
How many failed patients for reconstructed?
Do you mean the whole samples of the patients, Dr. Diah?
Yeah.
How many patients that you have observed, Dr. Menik, to make conclusion that about your recurrence rate? Dr. Menik? How many patients have you observed to make this conclusion?
About 30 cases, Doctor.
Is this reply to your question, Dr. Diah?
And then until now, there has not been any failed patient, Doctor, because we still follow up the patient and make the patient control to our hospital every 6 months.
Oh yeah, thank you. It's a
Thank-
good news.
Thank you,
success
Dr. Diah, for the
this.
question.
Thank you, Dr. Diah, for the question and Dr. Menik for the explanation. And now I would like to give the opportunity for Dr. Vitor Simoes. Do you have any question to the other speaker? Dr. Vitor Simoes? Do you have
That's a
any?
little bit. I just saw the end of Dr. Menik presentation, so I'll pass the questions. Sorry.
Yeah. Do you have any questions for Dr. Menik? Okay, for the next, I would like to give the opportunity to Dr. Menik. Dr. Menik, do you have any question to the other speaker? Please unmute your microphone, Dr. Menik. Your microphone is muted. Okay.
No, I don't have a question for Dr. Peter. Dr. Peter, thank you.
I have a question to Dr. Vitor Simoes. Based on your experience, could you explain to what extent that the percutaneous drainage could give the proper treatment for the peritonitis? Thank you.
Well, in my experience, I have the opportunity to have excellent interventional radiologists, so they are always ready to do more and more advanced procedures. In case of localized peritonitis.
Yeah, in case of local peritonitis.
It's local peritonitis, yes. Of course, we are not talking about generalized peritonitis, we are talking about localized. They can perform all kinds of drainage, and they do like to perform. Of course, we know that some patients that want to be solved, the problem want to be completely solved with just with drainage. But if the patient is doing well, we can preserve his status. We can even improve and reduce infection and facilitate the the procedure later on. Remember some cases of abscesses in acute diverticulitis that we used to perform surgery and have to do extended resections. The patients had hemodynamic instability after surgery, infection, and now if there is a localized, we drain patients and get fitted well, they reduce the infection, and then when we have to perform the resection, they are clearly better than in other when we do not perform this. Same thing with cholecystitis, with liver abscesses, associated liver abscesses. They are complicated surgeries that normally in the acute setting they bleed. It's very easy to perform, have a common bile duct injury during the procedure. They bleed a lot, and if we perform the drainage first, patients do fare better. And when we have to do surgery, normally they are in better shape and they perform better after surgery.
Thank you, Dr. Vitor Semis, for your explanation. I have a question to Dr. Diah Asmarawatie. What are the indications of imaging during the surgery? So you go to the operation theater and make an imaging while the surgeon still working in the theater. Thank you.
Pardon, Dr. Peter.
What are the indications for the during surgery imaging in the operation theater while the surgeon is working in the theater, and then you make the imaging together in the same time?
Yeah, until now, usually special for the orthopedists, we do this. We have the experience with the orthopedists because it must do what the orthopedist done with the information from us. But until now, we have not experience for the other subspecialist surgeon.
So far, you have only the experience with the orthopedic surgeon.
Yeah.
Okay. How about the foreign body? If, for example, if there is a foreign body by the gunshot, and then the surgeon will look for the foreign body, did it need the imaging during the surgery? Because it's a small foreign body, it's very difficult to find out by marking only.
Oh yeah, I see. I have an experience several years ago when I still work in the RKZ hospital. There's maybe a robber, and there's with the bullet in the thorax. But after I make the reconstructed, and the surgeon seen in the workstation, and then do this and operate it basically on the reconstructed of the CT scan. It's enough for the surgeon. This is the bullet in the thorax cavity, and it's a success operation at this time. It's several years ago in Surabaya.
Okay, thank you for your explanation. And now I have a question for Dr. Menik. Dr. Menik, I would like to ask to what extent could the reconstruction give a good occlusion of the mandible? Based on your experience, did it need the second look operation or the second reconstruction because of the malocclusion? Thank you.
Usually, we do one-stage operation, doctor. And in that operation, we make the occlusion to the patient stable using ramus fixator. and using a wafer.
My point is not the about the quality or of the strength of the implant, but I'm asking about the occlusion, the possibility of the malocclusion of the first reconstruction. Did you need a second reconstruction because after the first reconstruction, there will be the malocclusion. So you need to make a second operation to make a correction. Can you explain about it? You said after 6 months, usually you make the second look, yeah, but it is not always a surgery. But if you find the malocclusion after the first reconstruction, to what extent you will need the second reconstruction? Please unmute your microphone. Your microphone is muted. Dr. Menik, your microphone is muted. Yeah, okay.
Hello?
Yes, please.
As long as the bone graft is already union and the occlusion could be achieved by implant device. So we can adjust the occlusion for the second procedure. Operation, I mean.
Okay, thank you. Dr. Frans, do you have any question?
Yes, Dr. Peter. The first one I'd like to address Dr. Diah. Actually, I find it very productive and very useful to have a discussion with the radiologist of the imaging before the operation. But in my personal experience, I don't think the radiologists have enough time to come to the operating theater and perform the real-time readings of the imaging. But do you think it's in the future, maybe for complex surgery, especially I find it quite hard in doing liver surgery because the liver is solid organ. We cannot find or we cannot easily detect the lesion inside the liver. Do you think it's a must in the future that a surgeon work together with the radiologist inside the operating theater? That's the first question. And the second question is there any technology that is available for the radiologist to perform a real-time diagnosis inside the operating theater? So these are the two questions for Dr. Diah. Should it be answered first, or should I I ask the other question, Dr. Peter?
Yeah, maybe one by one. Yeah, maybe
one by one. Okay.
Yeah, please, Dr. Diah, react to Dr. Frans' question.
Yeah, thank you, Dr. Frans. Surely it's good ideas, and actually this is true. This is a best way that the radiologist must stay beside the operator. But nowadays in Indonesia, the radiologist not so much radiologists nowadays. But I think after this, I hear from the head of the PDS, Dr. Terawan, that now radiologists have been increased in the PPDS in order to the radiologists can be work together with the surgeon. And for the real time, I think so. It's just ideal for the future, that radiologists must be there in the together with the surgeon and give the maximal and maximal information and detailed information in order to the successful of the surgeon. Thank you, Dr.
Yeah,
Frans.
thank you,
Hope it's
Dr. Diah.
successful for
I
you.
think so also, because if pre-operative discussion is beneficial, I think during the operation it will be most beneficial for the patient during the operation if there is a discussion between the surgeon and the radiologist. Thank you, Dr. Diah. The second question is to Dr. Vitor Simoes. What kind of antibiotics do you use for the first line treatment of intraperitoneal infection? As you mentioned that the guidelines suggest you give a broad spectrum antibiotics for the as soon as possible, especially after the diagnosis in the ER. In 1 hour, you should give antibiotics. Of course, there will be no cultures for yet on that time. So what kind of antibiotics, or what maybe what class of antibiotics do you use for the peritonitis? This is the first question. The second question is, I think the research that you showed us for the meta-analysis for conservative treatment for peritonitis is not for all types of peritonitis. I think it's if I'm not mistaken, it's only for appendicitis, perforated appendicitis, if I'm not mistaken. So of course that different type of cost of peritonitis may need different approaches. If I'm in my experience for the Hinchey type 1 or type 2, for the diverticulitis, it's a simple local drainage is okay. So we don't have to perform laparotomy or laparoscopic operation. But I don't know what is your experience on these matters. Thank you, Dr. Vitor Simoes.
Thank you so much for your questions. Well, about antibiotics, normally we start on piperacillin tazobactam. It's our guidelines, local guidelines. Okay, as I shown, broad and you said broadened spectrum antibiotics, start as early as possible, and then change according to the organ sensitivity of food and how well your patient is going. The work I showed you talked about alternatives according to the local experience and the availability. So you can also use meropenem, imipnem, or even cephalosporin, fourth generation one. So it depends on your experience, and probably it should be according to your profile and according to your local infections disease team. Okay, and probably all the surgeons should start more or less the same treatment according to your local hospital guidelines. About conservative treatment, yes, you said it perfectly well. Conservative treatment, and that the paper I shown was about acute appendicitis. It's for localized peritonitis, abscesses, so it's not for Inchi 3 or Inchi 4 that is generalized, purulent or fecal peritonitis. Well, the review that was done by Lila in Inchi 3 patients says that even in those patients with purulent peritonitis, you could do lavage, laparoscopic lavage and drainage. It's not that I have addressed a lot of patients like those. Fortunately, they are not that frequent. I have performed some. The first time I did it, I was not very comfortable, but the patient did very well. So it's not very for a surgeon and for myself. I do like to find the spot and to solve it, even if I suture it or if I perform a resection. I feel more comfortable many times. If it is an Inchi 4, of course, you will not do just a lavage because there is fecal content inside the abdominal. Inchi 3, we are doing more and more. But when you go to the studies, Delilah and so on, you know that there are some problems in the classification, and there is 20 to 30% of patients that were not Inchi 3 but were Inchi 2. So I'm not totally convinced and totally comfortable with a laparoscopy lavage, but probably I would start with the laparoscopy with laparoscopy, try to make and see if it is possible, and if I'm confident and I'm that is the best treatment for the patient. I hope I answered you the question.
Yes, thank you very much. It answers the questions. Okay, thank you. I think we as a surgeon should differentiate or try to make our own decision based on the patient, rather than to see as the patient as a group of people with the same treatment or requiring the same treatment. Because I think even peritonitis or appendicitis has even diverticulitis. It's we have old patient, young patient, immunocompromised patient, obese patient, which may requires a different approach, I think. So it's still needed the judgment of the surgeon to do whether to do the conservative treatment or to do the more aggressive treatment. The last question is to Dr. Menik. Dr. Menik, do you always perform the 3D 3D, not reconstruction, the 3D modeling for the reconstruction of the mandibular resection? Because
Yes, doctor.
all of the patients are done.
For all the patient.
Okay, so it's very
Because
good.
it can help we in operating room.
So you do the pre bending of the plate before the operation is
you're
started.
right.
Okay.
Yes.
Excellent. Yeah, thank you. That's all I would like to know. Thank you, Dr. Menik.
Doctor.
Yes.
Thank you, Dr. Frans, for your questions. Any other questions from the floor? Professor Dodi, do you have any question? Okay. Okay, if there is no question anymore, I would like to express my gratitude to all the participants of this surgical forum, particularly for the speaker, Dr. Diah Asmarawatie, Dr. Victor Samwe, and Dr. Menik Sayekti, for your very interesting presentation, and also to all the office bearers of the International College of Surgeons Indonesia section, Professor Paul Tahlele, Professor Sri Maliawan, Professor Hendy Hendarto, and Professor Dr. Frans Arifin, and our IT team, Mr. Bimo and Ms. Dewi, for all your contribution in this webinar of the Indonesian section. We will meet next month in the different topic and different speakers. And again, I would like to thank all of you for your participation in this virtual forum. Stay healthy and well. Thank you very much. Good night, and till we meet again. Thank you.
Good night, Dr. Peter.
Thank you,
Good night,
Dr.
everybody.
Thank
Peter.
you.
Thank you.
Thank
See you
you,
next
Dr.
month.
Peter. Thank you, Dr. Frans.
Thank you, Dr. Diah.